the continuation of the previous class. So we'll see about the mandibular nerve block. In 1970, George Gates first published this technique. This is called as open mouth technique. The Vajrayani echinosis is another technique which is called as closed mouth technique, whereas Gauguet's is a open mouth technique. What is the significant advantage of Gauguet's technique over the other inferior nerve block technique? It includes high success rate, its lower incidence of post aspiration, and the absence of problem with the accessory sensory innervation to the mandibular tip. The nerve that get anesthetized will be the inferior alveolar nerve, lingual nerve, buccinator nerve, mental nerve, mylohyoid, and auricular temporal nerve. Area anesthetized will be the all mandibular hard and soft tissues to the midline, floor of the mouth, anterior two-third of tongue, lingual soft tissue and periosteum, skin over the zygoma, posterior portion of the cheek, temporal region, and the portion of external ear. Alternate to the Gauguet's technique, we'll have Vajrayani echinosis, incisor nerve block, inferior and buccal nerve block, mental nerve block, buccal supraperiosteal injection, intraosseous, and a perial injection. Landmarks: anterior border of the ramus of mandible, tendon of temporalis muscle, corner of the mouth, intertracheal notch, and then external ear. Intraorally, the height of injection is established by placement of the needle tip just below the mesiolingual cusp of the maxillary second molar. It's most commonly indicated in operative and surgical procedures on the mandibular teeth when the lingual soft tissue anesthesia is necessary, diagnostic and the therapeutic purposes. Needle pathway during insertion. The patient mouth is wide open and the needle is inserted at the point lateral to the pterygoid depression, but medial to the tendon on the plane. Approximating structures will be inferior to the condyle, inferior to the attachment of lateral pterygoid muscle. Technique: patient is placed in a supine position. Operator is positioned to the right and slightly front of the patient. Patient keeps the mouth open widely and remains in that position until the injection is completed. This position moves the condyle anteriorly, thus facilitating the injection. An imaginary line is drawn from the corner of the mouth to the intertracheal notch. So this is a picture which shows that where the imaginary line has been drawn. It's drawn from the corner of the mouth to the intertracheal notch. Place your index finger or a thumb on the coronary notch. Determination of the coronary notch is not essential to the success of Gauguet. It enables the soft tissue to retract it and aids in determination of site of the needle penetration. Visualize the internal landmarks, which includes mesiolingual or the mesiopalatal cusp of the maxillary second molar. Needle penetration site is just distal to the maxillary second molar at the height of tip of mesiolingual cusp. Prepare the tissue at the site of penetration. Dry the tissue with sterile gauze. Apply topical antiseptic and apply topical anesthetic for a minute. Direct the syringe towards the site of injection from the corner of the mouth on the opposite side. Insert the needle gently into the tissues at the injection site distal to the maxillary second molar at the height of its mesiolingual cusp. Align the needle with the plane extending from the corner of the mouth on the opposite side to the intertracheal notch on the side of the injection. Direct the syringe towards the target area on the tragus. The syringe barrel lies in the corner of the premolar, but its position may vary from the molar to incisor depending on the divergence of ramus as assessed by the angle of the ear or to the side of the face. The height of insertion above the occlusal plane. So this is also similar to that of the standard inferior alveolar nerve technique. When a maxillary third molar is present in normal occlusion, the site of needle penetration is just distal to that too. Slowly advance the needle until the bone is contacted. Bone contacted in the neck of the condyle. Average depth of soft tissue penetration to bone is 25 mm, although some variation has been observed. If the bone is not contacted, if you are not able to contact the bone, withdraw the needle slightly and redirect it. Move the barrel of the syringe somewhat more distally, thereby angulating the needle tip anteriorly and re-advance the needle until the bone contact is made. A cause of the failure to contact the bone is partial closure of the mouth. Thickness of the tissues increases. If bone does not contact it, do not display any of the local anesthetic solution. Aspiration has to be done in a tube plane. If it is negative aspiration, slowly deposit the anesthetic solution. Finally, you will achieve the nerve block. Before a commencement of any procedure, wait for 5 minutes and allow the nerve block to completely anesthetize the region. Signs: subjective, tingling or numbness of the lip and the numbness of the tongue, and objective, the patient will not have any pain. So this is the technique of target area of a Gauge technique, which is nothing but the target area will along the end of the condyle. So the concept of this, how much of we have seen is mandibular nerve technique, Gauge technique, the target area will be the condyle end. Coming to the recent technique, which includes fixed technique, it has been recently introduced and it is nothing but the needle is directed towards the lingula. So remember, it's directed towards the lingula. Coming to the infraalveolar block technique through retromolar trigger, it is a technique of choice in a patient suffering from blood dyscrasis. Needle is inserted directly into the retromolar trigger. So this is the one of the technique, advanced recent technique, where it is indicated in the patient is suffering from the blood dyscrasis. The needle is inserted directly into the retromolar trigger, 5 mm from the distal surface of last molar. Coming to the technique which is used for pediatric patient, which includes inverted triangle concept given by Matthewson. This technique is used to estimate the position of infraalveolar nerve in the pediatric patient. The coronary notch is palpated similar to that of any other technique is used. An imaginary triangle. See, this is an imaginary triangle. This is a picture shows that imaginary triangle which has been drawn by the anterior border of the ramus of the mandible, internal pterygoid muscle, and the vault of the palate apex directed inferiorly, and another imaginary line which divides the tip of the finger or a thumb position at the coronary notch, passing medially over a depressed area above the apex. Once the bone is contacted, deposit the solution. I'm just repeating it again. An imaginary triangle has been drawn between the anterior border of the ramus of the mandible and the apex of the palate. And another line is to bisect the thumb or the index finger. So in between these triangles, you have to inject and deposit the solution. This is called as a thumb technique, which is introduced, triangle concept, which is introduced by the Matthewson. Coming into the thumb concept by right. So this is the concept which is given by the right. For a right infraalveolar nerve block, the left thumbnail is positioned over a coronary notch and slightly over a deep tendon of a temporalis muscle. The needle is inserted at the middle of the thumbnail between the deep tendon of the temporalis and pterygomandibular raphe, entering into the mandibular sulcus at the level of lingual notch. So this is the thumb concept, which is given by the right, and the previous one which we have seen is a triangular concept, which is given by the Matthewson, and the remaining is called as fixed technique, and we have seen an inferior alveolar technique by the retromolar trigger. So this is, they are all the picture is overall pictures of variations of inferior alveolar technique, and this is a conventional technique. This is a Fisher's 1 to thread technique, and this is a retromolar trigger technique, an anterior ramus technique. Vazirania kinosi, where you can able to appreciate the patient has been closed his mouth, oriented the needle along the occlusal palate to the top of the occlusal plate. So this is a Gauge technique, which is called as open nose technique, where you are going to deposit the solution along the coronary head. So this picture shows the extraoral technique. I'll explain you in detail about the extraoral technique in upcoming classes. Coming into the lingual nerve block. Lingual nerve block, the nerve that gets anesthetized will be the lingual nerve. Area anesthetized will be the anterior two-third of the tongue on the floor of the oral cavity, mucosa, and the periosteum on the lingual side of the mandible. Anatomical landmark is same as that of inferior alveolar nerve. Indication for surgical procedures of anterior two-third of tongue, floor of the cavity, and mucous membrane on lingual side of the tongue. Technique to block a lingual nerve. Blocking a lingual nerve at the same time as an intraoral inferior dental injection. So as I told, along with that of, so in the standard inferior alveolar technique, you can also block the lingual nerve by giving a submucous infiltration of 0.5 ml, a few millimeters below, behind the region of the lower third molar on its lingual aspect. Infiltration is immediately lingual to gingiva or a mucosa to be treated. Either you can give in that manner or you can give in this manner. Subjective is numbness or tingling sensation in anterior two-third of the tongue. Objective is instrumentation is necessary to demonstrate whether the patient is not having any of the pain. Coming to the buccinator technique. Buccinator, which is also called as a long buccal nerve technique. Nerve anesthetized will be the buccal branches of the mandibular nerve. Area anesthetized will be soft tissue in the periosteum buccal to mandibular molar teeth. Area of insertion will be mucous membrane distal and buccal to the most distal molar teeth. Anatomical landmark is external oblique ridge, retromolar triangles, and the mandibular molars. You can able to appreciate the retromolar triangle, mandibular molars, and then retromolar fossa depression posterior to the teeth. Technique: a 25 gauge needle is inserted into the buccal mucosa just distal to the third molar. 0.5 ml of solution is deposited in this area. An alternate technique is that is to insert the needle and deposit solution directly into the triangle. Symptoms: the patient will not have any of the subjective symptoms because of the localization and small size of anesthetic area. Coming into the mental nerve block technique. Nerve anesthetized will be the mental nerve. Area anesthetized will be the lower lip, mucous membrane in the mucobuccal fold anterior to foramen. Landmark will be the mandibular bicuspid. It's nothing but premolar. Indication: procedures where a manipulation of buccal soft tissue anterior to the foramen is necessary. Contraindication: acute inflammation and infection over the injection site. Positive aspiration of 5.7%. Alternates: local infiltration, IANB, Gauge, or Vazirani technique. Locate the mental foramen technique. Place your index finger in the mucobuccal fold. Press against the body of mandible in the first molar area. Move your finger slowly anteriorly until the bone beneath your finger feels irregular and somewhat concave. The bone posterior and anterior to the foramen is smooth. However, the bone immediately around the foramen is rougher. Remember this. The foramen is usually around the apex of second premolar. Remember, the patient may command the finger pressure in this area that produces soreness as the nerve is compressed against the bone. The apicus of the tooth should be estimated. 25 gauge needle should be inserted. The tissue is penetrated until you touch the periosteum of the mandible in the region to the apex of second premolar. The depth of penetration is 5 to 6 mm and the solution deposited is 1 ml. Symptom: so this is a pictorial representation shows where you are going to give the mental nerve block. Symptom: tingling and numbness of lower lip. The patient doesn't have pain during a treatment. Complication is emetema, partial anesthesia of central and the lateral incisor. Coming into the incisor nerve, area anesthetized will be incisor nerve and mental nerve. Nerve anesthetized area will be lower lip, mandible, overlying structures anterior to foramen, bicuspid, canine, and incisor. Anatomical landmark is mandibular bicuspid. Indication: structures anterior to foramen where IND is contraindicated. Alternates: local infiltration for buccal soft tissue and pulpal anesthesia of central and lateral incisor. Inferior alveolar nerve block, curve gauge, Vazirani, and PDL or the alternate technique. Technique is similar to that of the mental nerve block technique. During the injection, a gentle finger pressure has to be maintained. Remember, symptoms: numbness and tingling of lower lip. Objectives will be anesthesia of anterior teeth. Failure: if you are going to deposit inadequate volume, inadequate duration of pressure. Complication will be emetema. Coming into the blocks of terminal branches, the nerve anesthetized will be the terminal branches within the mandible. Area anesthetized will be area innervated by the terminal branches. Indicated whenever the successful 6 anterior teeth procedure has to be done in that teeth. The technique is paraperiosteal introsus technique. Symptom: doesn't have subjective and objective symptoms are there. Coming to the local infiltration, nerve anesthetized will be free nerve endings in the infiltrated area. Area anesthetized will be mucoperiosteum in the infiltrated area, mucous membrane. Landmarks: there is no precise anatomical landmarks because like if you are going to do the procedure in central incisor, mandibular central incisor, you are going to insert the needle parallel to the central incisor. Suppose you are going to do a procedure in premolar, you are going to insert the needle parallel to the premolar. Indication: anesthesia of restricted area of mucous membrane. Technique: a 25 gauge needle is inserted beneath the mucous membrane into the underlying structures and the area is infiltrated with the anesthetic solution. More than one needle insertion may be necessary. Symptoms: there is no objective symptoms, subjective symptoms. Objectives: instrumentation is required. Thank you. As of now, we have seen there are accessory techniques and the most important of Gauge technique and the remaining recently introduced technique like fixed thumbs concept, triangular concept technique, pediatric techniques, and we have seen few of the mild minor techniques like mental nerve block, lingual nerve block technique, buccal nerve block technique, and we have seen incisor nerve block, and we have seen about the local infiltration techniques. So this completes the intraoral technique of mandibular nerve block. The only remaining topic in mandibular nerve block is the extraoral technique, and we will see that in detail in the upcoming classes. Thanks for listening. Thank you.